FACO pearls to make it an enjoyable experience. I would like to request my co-speakers, co-instructors to come and join us on the dais. Dr. Sudeep Das, Dr. Sandhya Nair, Dr. Matthew Kurian, and Dr. Reshma Padmaram. I have a host of very experienced FACO surgeons and very experienced retina surgeon with us to address us. Most of them do not need any introduction, but for the sake of introduction, I will just mention. On the patient positioning, surgeon positioning and wound construction, I'll be talking about, followed by tips to make hydro procedures safe and easy and effective by Dr. Sudeep Das. Sudeep Das is a prolific cataract surgeon with a very large experience and a high volume surgeon. He had a very long stint in Narayan Nethralaya. Presently, he is the medical superintendent of and medical director of Shankara Eye Hospitals, Orissa. Then, to talk about tips to make nucleus management easy and effective, we have Dr. Sandhya, who is a very senior cataract surgeon and a very experienced high volume surgeon and a UVA consultant at Giridhar Eye Hospital, Cochin. We have Dr. Matthew Kurian, who is again a prolific and well-experienced cataract surgeon who had, along with Sudeep Das, had a long stint in Narayan Nethralaya. Presently, the medical superintendent of Chaitanya Eye Hospital, Cochin. I'll be dealing with PC rents, how to deal with it. And we have Dr. Reshma Padmaram, very daring, very experienced and dynamic retinal surgeon. She had her training in Netradama. She also worked in Dr. Agarwal's Eye Hospital and presently, and Vasan Eye Hospital, presently in Al Salama, Perindalmanna. She'll talk about when to hand over a case to a retina surgeon, especially in a fragment drop or in a rent, when to stop fiddling with the nucleus and handing to what to do and what not to do. And we'll have a panel discussion at the end of the time. So I'll go ahead with my first talk. Patient positioning, surgeon positioning, wound construction and rexis. See, it's very important to make the patient very comfortable during surgery because he may be anxious, most of the time anxious. So making him least irritated during surgery is very important. So you have to use your verbal tactics as well as the surgical tactics to handle this situation. No financial disclosures. So when you look at the patient, see, when the patient walks in itself, you have a look at the patient. So when you see this patient, okay, he's walking in a wheelchair. So you have to expect that this person may be having a post-stroke weakness. He may be having a shivering of the head, etc., etc. So while walking in, you can just gently talk to him and telling him a few good words probably will make him more comfortable. And now shifting the patient, okay, and making the patient comfortable while lying down. This is very important. Especially in a topical phaco, we need the patient to cooperate as much as possible regarding the head position as well as the positioning. See, when you make the patient lie down, you have to make sure he lies down in an adequate position where the head end reaches the end of the headrest. If there is a gap in between, you can have a problem. If his head is tilted to one side, again you can have a problem. So all these have to be taken care of by the sisters. It's always better if you're sitting in the OR room. Make sure that you supervise how they position the patient. Most of the time the patient will have a habit of turning the head to one side. And if you just walk in and sit, you will not get the ideal position in which you require. Yeah, again, this is also about head positioning. Yeah, you may need to lift the patient, especially if the patient is having some weakness of the arms, etc. You will need to just pull him up and position him properly. Yeah, again, very important is the surgeon's position. Now we have made the head position in such a way that the head is parallel. You have to look at the chin. It is not tilted up or tilted down. So make it in such a position that it's comfortable. Now make sure the surgeon also sits properly. He is neither leaning forward nor away. it should be in the ideal position. You can also adjust the microscope, the tilt, and make sure most of the time the knob of the lighting position will be halfway through. You suddenly start, you will not know what is happening. Always have just touch this thing so that it is in the position 1 or position 2. So this is also very important. Yeah, this is what I was talking about. If you want to tilt, you can tilt. And then putting the speculum also is an art. So this is the time you also talk to the patient. While the microscope is being adjusted, you talk to the patient. The speculum, if it is too tight or too loose, both can cause a pressure on the globe, positive pressure, and you can expect a PC run in these cases. So be careful while applying the speculum. Always talk to the patient. If it is too tight, the patient will scream. If it is too loose, he will not say anything, but you will again have the pressure of the this thing sitting on. So the ideal position, you should titrate and make sure you get it adequately. Now, I always do a saline wash in the beginning. This is also a patient training. The patient has to fixate on the light. So when you push saline, keep on pushing saline, ask him to keep looking at the light and tell him that this is going to happen many number of times during the surgery. So keep your eye. It's a training for him to prevent the bell phenomenon from rolling over. And if you find any pooling, then that means the head position is not correct. You can just tilt a little bit this way or that way so that there is no pooling. That make sure that pulling doesn't happen during the surgery and the patient is in the ideal position. And it also helps in prevention of TAS. All the viscoelastic, the betadine which you have put also is washed off. So this is basically essentially the same thing. You are washing and asking the patient to concentrate and look at you see the patient is looking perfectly. And again, you always use the proper positioning of the instrument, a penhole technique or whichever is easy for you. You make sure you get into that habit so that you don't make the wrong incisions. So this is how the incision is being made. Okay, now wound construction, it is always better to avoid holding or touching the conjunctiva because that is a painful area. It doesn't get fully anesthetized with the topical paracaine which you put. And it also gives you a quiet and white eye and with minimal post-op irritation because holding the conjunctiva, there will be Dellen formation, etc., etc. Try to handle only the cornea in these cases. Like if you see here, yeah. Here what I am trying to do is, see, I am using the side port MVR to stabilize the globe and then I am making the section. So nowhere the conjunctiva is being touched. So once the tunnel is created, then you can put the second MVR incision also. So without touching, all the incisions are over and it's a fast procedure. Now going on to the rhexis, again it's a good idea to not hold the conjunctiva. You can use a rhexis marker. If you are one of those privileged ones, you can use the Varion system. Okay, so once you mark, you can go in through the side port with the, it is your choice whether you want a rhexis needle or you want a utrata forceps. But whatever it is, a few tips I will tell you. One is you can either raise a linear incision or you can raise a flap. Either way, it doesn't matter. Sometimes this is the flap being raised, and you move around. You have the marking of the rhexis outward. This is around 5.5 millimeters, and you could keep moving. As you do that, try to keep folding the rhexis margin. You keep moving the rhexis margin and folding it over it, so that that itself will act as a guide. So yeah, see here I am folding it over, and even wherever you need to see, you just go and just fold it over and make it flat. So that makes it very easy to have a good control over your rhexis flap. And this is how, and always try to overlap the last part of it. You try to overlap rather than making into a heart-shaped incision. So these are a few tips in making the initial steps of topical phaco easy. Thank you very much for a patient hearing.